To run too late. I'd like to thank my partner, Dr. Vitale, who I think is outside, for letting me share one of his cases with him, or with you. So this is another one of these, old case, goes back over a decade when maybe we didn't do things exactly the same way. And I think one of the problems we have had and have gotten away from is surgically, putting metal inside very young children. Like, this is a 2.5-year-old boy with a chromosomal abnormality, multiple medical comorbidities. And the decision was made at this point in time, given the history and the rapid progression. I think that's something that we talk a lot about at our institution. It's never an absolute number that you're going to operate on. It's not like knee-jerk 50. It's like if this kid's progressed 30 degrees in the last 6 months, that something's happening, and that's probably a reason or indication to treat. A little bit of K, but really sagittal profile didn't look too much. So he had a VEPTR. You can see it's his first-generation VEPTR that was put in, rib to spine. That was sort of the standard construct, certainly, a decade ago, and everything looked okay. Unfortunately, he started to fall off. You could even maybe get a little bit of a sense he's starting to do that in these immediate post-op films on the sagittal plane. He does have a little bit of PJK, and that's immediately post-operative. And he ultimately ended up pulling off completely, and that left hook in particular was becoming very prominent, threatening the skin, needed to be moved down because it had plowed through those ribs. You couldn't put it back in the same place. Sagittal plane looked basically the same at this point, but again, he's 3 years old. 6 months later, he's already had his second surgery. And here we are 6 months later, so he's now only a year out from his primary surgery. That left rod again became prominent, was really starting to come out of the skin again, and at this point there's really no good options for having a construct on that side, so they opted to remove that rod and just go to a single rod, just to kind of buy time and see how he does going on. And he did okay for a little bit, but 10 months later, he's now completely pulled off the second rod. Again, he keeps falling away from this rigid construct, small kid. He's now getting close to 4 years old. We're about 2 years out from his primary surgery. He's already had 3 surgeries. And you can see here he's come off, and compare him to where he was initially to where he is now. He's clearly progressing with prominent hardware. So this is now his 4th surgery, in 18 months. And again, they ended up putting a new, again, still we didn't have 2nd-generation stuff, went with a new 1st-generation cradle, and moved him down a little bit. Again, I know the x-ray doesn't look great. He was placed on the rod initially, and they placed a new rib distraction construct in as well. But again, we're getting to see the same problems. And it's like, I guess if you keep doing the same thing over and over again and you're expecting something different, right, that's the definition of insanity. Sometimes it just gets really difficult, right? So again, failed proximally again. This x-ray looks not that dissimilar to what we saw about a year ago. And so at some point you need to be like, okay, we kind of need to do something different. So he was revised again. And again, he failed again. We didn't have films. At this point, he's had so many films, I think they ended up, losing some of them. So they ended up just taking everything out at this point in time.
Just at this point, tell us about this. Where was this in the evolution of rib-based anchors and instrumentation and those kind of?
So we are. So again, this is 2009 to 2011. I think where we've been right now. The prevailing constructs were really rib to spine. Again, rib to pelvis. The predominant thinking at that time was stay off the spine completely, preserve flexibility, have a little micro motion between the ribs and the spine. Putting pedicle screws in a 2-year-old is certainly a challenge and something that we try very hard to get away from even today. And there was really not much in the way of other types of implants like we have today, as far as the laminar style hooks that we place on those ribs. And again, I think even though it's pretty obvious from looking at this, one of the things which we know, which is really critical and has been mentioned multiple times before, is the number of anchor points that we have proximally to help prevent failure, right? So 5 seems to sort of be the magic number. 1 is clearly not going to be a long-term solution, but sometimes you're just kind of treading water, letting the kid get big enough that you can put something else in.
What do you think is the role of diminished lumbar lordosis in this case? You only had limited amount of rod bending down there, and he was always out of balance anteriorly, so he has a big lever arm to the apex of the thoracic kyphosis. Do you think this plays a major role in this case?
So, right, the sagittal plane is not just the thoracic spine. Obviously, it includes the lumbar spine as well. Going back, he's pretty similar to where he was initially. I think that he was pretty much contoured in situ to the way he was initially. Of course, at 2.5, this kid was developmentally delayed. He was, crawling. At this point, he's able to walk, but he wasn't walking initially. That may have been some of the reason that he hadn't fully developed his lumbar lordosis yet. And we then certainly prevented him from developing any additional lordosis by having this in there. So by minimizing his lordosis, are we increasing the likelihood or propensity for him to develop the thoracic kyphosis? I mean, there's probably something, something to be said for that. It certainly wasn't helping. Yes?
Yeah, just a stupid question. What made you decide to go for surgery? The case that you showed initially would be raising, for us now.
Right. So, and again, keeping in mind the time bias, right? I think that if this same patient came in today, I don't think that this would have been the primary option for this kid. The thinking, again, at that time was this was it was really a rate of progression at that point in time. So I didn't we have 10 minutes, I wasn't going to go back an eternity, but this kid had rapid progression over the previous 12 months of about 25 degrees or something along those lines. And so when you're seeing progression at that rate at that point in time, that seems to be a pretty good indicator that you need to intervene. Would casting have been a good option for him? Probably, but again, 10 years ago, we weren't really doing a whole lot of casting.
Dr. Mehta?
Although we have focused so much on the sagittal profile, the fact that your trunk's shifting a lot, you don't think that an Eiffel Tower type construct would help hold things up? That might protect your domain as well.
So, well, that's what we had initially, right? So we started with that and just could not maintain it. That was the difficulty with maintaining that left rod. His ribs were not supporting the convex rod, not the concave side. And he lost twice. He plowed those rods. I mean, there was really no other option for a fixation point on that side. But I'm going to move. Yeah, sorry.
No, thanks for sharing this case, because this is a perfect example of how we have kind of learned iteratively from each other. And so I think I've heard 4 different reasons why this kid could have had implant failures. Either failure of this type of implant to be able to accommodate this patient's proximal thoracic kyphosis, the lack of contouring in the lumbar spine, the lack of sufficient number of anchors proximally, and then the age at intervention. So I don't know, maybe we should have a poll, like who thinks, what's the main reason why this happened? Who thinks, well, yeah, patients, so again, is that age specific or something like that? So.
I mean, look at his bonus. So, I mean, his vitamin D is one of the other things, really simple, easy to treat, but I bet his vitamin D nutritionally is.
And also don't forget muscle balance, because we really depend on our muscles to hold us in extension, and we're not really sure that he's got developmentally the ability to do that. So that's why achondroplasts are so kyphotic initially, because they're hypotonic during that phase.
So yeah, maybe we'll do a show of hands of who thinks all right, not to put you guys under the bus, the biggest mistake here, is it proximal anchor contouring A? Anybody think that's the, or proximal contouring of the rod or the sagittal profiles? Anybody think that's the biggest problem? How about number of anchors? Who thinks that's the biggest problem? Okay, interesting. And then who thinks it's the lumbar sagittal contouring? Exactly. So Bob Campbell's solution to this construct when he experienced PJK was to just go in when he did a lengthening, put more lumbar lordosis in. Yeah. Yeah.
I look at it the opposite. If the kid's looking to find kyphosis, so if you take kyphosis away from their spine, they're going to add it on somewhere.
Particularly for the ambulatory ones, where he had ambulatory kids of the pelvis where they were sort of out of the way.
But ideally, you want to have your C7 plumb line going through S1, going through your hips in terms of just overall balance.
So,
Talking about the PJK, we always think about how to treat the PJK. Actually, we need to think about what happens, what caused the PJK. So all the growing rod system, all the magnetic control, the growing rod system, they are not to keep the spine going every second. They are intermittent, 1 month, 6 months. Between this period, the spine was tension. So this is the reason to cause PJK.
Interesting. Okay.
This kid had almost very few lengthenings because of the number of revisions as it ended up turning out. So anyway, so his implants ended up needing to be taken out due to skin problems. He actually looked a little better, honestly, sagittally, when the implant came out. So just removing that stiff lever arm back there provided some help because he got infected, and that's why the rod ended up being taken out. The infection was noted proximally, but actually was noted to extend down the length of the rod. So everything was taken out. Rod was, after the rod was taken out, MRI revealed a tethered cord. I don't think he'd had an MRI previously, and he underwent a tethered cord release and an instrumentation to the lumbar spine in preparation as an anchor point for the future. Again, he had continued progression because at this point he'd been about a year without any implants in him or any meaningful implants in him. And now at this point, he is now on his, fifth or sixth major surgery at this point in time, but we're 5 years later, and so we've learned a little bit more. So he got the additional anchor points that we needed. He got 6 anchors approximately, had reasonable correction, and actually this lasted him for a good 5 years. So I think that would help make the argument. I mean, he's older, probably has better bone quality at this point. The ribs are certainly bigger than they were 3 years previously, but we bought time. Did not prevent the PJK, but at least we prevented the complete loss of fixation proximally and the hardware migration and the skin problems and the infection and things like that.
So just what do you think about, you've changed your caudal fixation from pelvic to lumbar. Do you think that helps you in terms of your sagittal plane correction? And that when you tie a kid up at 2 to the pelvis, does that limit their ability to compensate?
Well, if you're to the pelvis, they really have no capacity to try to compensate at all. And so by coming off the pelvis, now this can be an issue because this kid spent 5 years of his life, meaningful years of his life, without using really those musculatures to posture him at all. And I've had some kids that I've done this on that have just fallen forward. They were completely unable to support themselves. This kid fortunately was able to kind of hold himself and held himself up for 5 years. And I do think obviously there's real benefit to avoiding the spine if you can, in ambulatory patients in particular.
You said you detethered, right?
Yeah, he was detethered.
Do you think that had any role in it?
He didn't really improve afterwards, so I'm not sure that really had an impact. I think the thinking was he'd gotten bigger, and I honestly don't even remember, it's so long ago, the actual indication for the MRI at that point in time, but the thought was to do a staged anchor placement, which has certainly been described by others, and I think a lot of us have done. I know we're kind of running low on time. Was there another point?
Yeah, just a quick comment about going to the pelvis and the ambulators, that every time you lengthen, that's going to increase the pelvic tilt or the lateral verge, so sacral slope changes. They want to try to get more lumbar lordosis because of that, but they can't. So they're locked everywhere. The only place they can compensate is at the top of the construct. So I think we found that it's not a good idea to go to the pelvis.
An ambulate. Do you think if you have 5 in the pelvis, that helps that at all? Does that protect the pelvis at all, having 5 instrumented, or not really?
I don't think that makes a difference. I think we do exactly
Yeah. Okay, so just to jump to the end. So now the kid's 10 years old. I just want to get to the very last slide so we can move on to the next case. Just kind of talk about how do we actually manage this. So at 10, he was still little, open triradius. After discussion, decision was made to translate him to a MCGR because he had run out of room on his VEPTR. And this lasted him for 2 years, and again, he did pretty well, but again, certainly had progression of that PJK, which is pretty clear here. You can see how far forward. He's got 30, 40 degrees of kyphosis up at the top. So he was then, when he ran out of room with that, he's now 13 years old and he's more mature. The plan was made to bring him back for a PS, posterior fusion, T2 to L4. Unfortunately, he had loss of motors during the procedure. And was left, they ended up aborting the procedure, leaving with a single rod, basically as he was previously, just to kind of help control things. And he fortunately had complete recovery of his neurologic function, but also predictably, he had significant continued progression of his PJK. So ultimately went back and needed to be revised. And this construct, you've seen earlier today, because he's, has so far kyphotic, needed to get up into the cervical spine in order to get him corrected. And again, but the use of cervical pedicle screws really help preserve the ability to just go to the lower cervical spine and avoid needing to go up to the upper cervical spine with fixation, and avoided instrumenting the concavity of the curve just because of his previous neurologic problems. And he has, done well 2 years after this procedure. So I'm going to stop there so we can get on to Pat's case.
Thanks, Ben. Any last questions for Ben while Pat's loading up his case? I thought it was a great look at where we've come in terms of our thinking and decision-making, and you're right, some of the things that were done 10 years ago certainly aren't done today, but thank you for
But
sharing.
we all, again, everyone's, learning as we go, because a lot of this stuff hasn't been done before.
So what would you do now if you saw him from that 1, 2-year-old?
Right.
How would you
I
start?
think that at this point, and I tried really, really hard not, to wait as long as possible. I think is the point, I don't remember who had made before, is like, yeah, absolutely, casting, if this is a kid that will tolerate casting, if not bracing, but really kind of waiting